All right, cool. So this is our last and final episode. Thank you for joining, everyone. It's really been a privilege to get to do all of these presentations for you all. So I'm very grateful for everyone's attention and being a part of this. It was really cool. So I just wanted to start off by saying thank you to all of you. And I should say what we're going to talk about tonight. So tonight we're going to talk about cardiovascular and neurologic emergencies, of some of the more scary things that we can see on the Hill, but things that are really important for us to have a good kind of radar of knowing what we're going to do and when we're going to kind of prioritize load and go. So we've talked about this a lot throughout the series, but again, I just think it is so important to recognize the environment that we are practicing in. We really have limited capabilities at our disposal, and as we talk about things tonight, we don't have EKGs to look at heart rhythms. We don't have CT scanners to do head CTs and figure out strokes, and so really what we have is the ability to recognize these emergencies quickly and then expedite our transport and treatment to help ensure that our patients get to that higher level of care. So if you look afterwards and you want to refresh on these, Chapter 15 talks about cardiovascular emergencies, Chapter 11 about altered mental status, and then Chapter 28 about some of the altitude-related neurologic emergencies that we're going to talk about. So our primary patient assessment is really important when we start talking about cardiac and neuro emergencies, because we really want to have a pretty quick assessment of, is this person big sick or little sick? Is this someone that's having a life-threatening emergency, or do we have a little bit of time to see what's going on? And so OEC6, we have starting, if we have someone bleeding, we're doing CABD. If we have someone that is not having life-threatening bleeding, it should say ABCD. And then looking at our other, kind of parallels in modern EMS, and also what we have from tactical combat casualty care. Another really important thing to be thinking about in a patient that is big sick is hypothermia, and making sure that we're addressing environmental exposure. So I think history taking is one of the really important skill sets that we have when we have someone with a medical condition, like a heart attack or like a stroke, where we really want to get a good history. Past medical history is really important. When it comes to heart attack, I think it's 7 in 10 patients that have their first heart attack had a history of high blood pressure. And for stroke, 8 out of 10 patients had a history of high blood pressure. So, thinking about things like high blood pressure, heart problems, all of those things are going to clue us in pretty quickly. And then medications that they're taking or may have prescribed is going to be important for heart attack. We'll talk about 2 of the meds that OEC6 talks about. And then even something like diabetes. So diabetes is one of the medical conditions that can give you atypical chest pain presentation because they may have some, nerve damage from their high diabetes, where they're not having the kind of typical pain syndromes that you would have when we think of the kind of classic chest pain scenario. So I like to ask my patients if they've been told they have a history of a certain list. So I'll say, high blood pressure, high cholesterol, heart problems, diabetes, because I found that patients will often think that because they take their blood pressure medicine now, they don't have high blood pressure anymore. So they don't recognize that it's still a medical condition for them. So as we talk about the different cardiovascular conditions, I think it's important for us to have good role clarity here. And so as OEC technicians, we're not there to diagnose the underlying cause of whatever their problem is. We're trying to quickly recognize patients that have signs and symptoms of something emergent and quickly initiate life-saving treatment, which in a lot of these patients is going to be expediting their transport off the mountain. So we'll start off with a question here. So we got a 68-year-old female. She's complaining of this kind of sudden, profound fatigue and shortness of breath. She denies having any, chest pain, but she does mention this kind of vague ache in her upper back and maybe a little bit of pain in her jaw, and she's having some nausea. She looks pale, she's diaphoretic, and her systolic blood pressure is 142. So what best describes her likely condition? If you want to post in the chat what you think the answer is here. Is it A, that a heart attack's unlikely because she doesn't have chest pain? Is it B, that she's likely experiencing a silent myocardial infarction, that she's experiencing classic angina, or that she's exhibiting signs of an abdominal aortic aneurysm? So this is one of the atypical presentation that women are kind of known to present with. You can also have it in diabetic patients. You can also have it in elderly patients. So when we talk about a silent myocardial infarction, what it is meaning is that they're having an acute heart attack, but they are not having chest pain. And this will actually be the presentation about a third of all patients that are presenting with heart attack have no chest pain at all. And so, we call it silent. That's kind of a bad suggestion because it makes it seem like it's less acute, but these are still, absolutely a heart attack. They just are not having active chest pain. And so they will still have some sort of symptom. And so the most common complaints that you'll have in patients that are having a atypical chest pain, they'll still have like shortness of breath and fatigue. They might get some kind of upper back pain, abdominal pain, and nausea. A third of all patients. It's much more prevalent in females, but when they look at the total aggregate heart attack, a third of them have no chest pain. So what we're going to do in these scenarios, right? This is going to be true for most of everything that we talk about tonight. This is another example of load and go. This person needs higher level care. They need to get an EKG. They need to get worked up. They need to go to an emergency room. And we're not going to have any of those kind of resources on the hill to be able to treat the underlying cause for this patient. So when we talk about myocardial infarction, we're talking about a heart attack. A lot of risk factors here. So people that have family history of heart attack are more likely to have heart attack. Men, especially elderly men, are more likely to have heart attack. Hypertension, so high blood pressure is a big risk factor. Smoking is a risk factor. Diabetes and high cholesterol. And so one of the red flags that when I'm kind of getting that history from a patient, what were you doing? What's going on? If someone has chest pain that stops them from doing whatever they were doing, that's a pretty good red flag that there's something that we really need to have our attention and really be focused on figuring out what's going on with that patient. It's unusual to have benign chest pain that actually stops you from doing whatever you were doing. Symptoms that also point to a cardiac origin. So if they are having kind of nausea, vomiting, really profuse sweating. So when I was an EMT and then throughout my medical career, heart attack patients are very diaphoretic a lot of the times. They really are having profuse sweating. Syncope is something, that's very worrisome. So if they faint or they become unconscious, palpitations are kind of that uncomfortable sensation of either like a rapid or pounding or fluttering or a regular heartbeat. Most people aren't aware and feeling their heart beating, but when they can feel it, that's a palpitation. And then shortness of breath is also very, very common in patients that are having a heart attack. So the typical chest pain is, patients will describe that elephant sitting on their chest. So it's a crushing pressure on their chest. It's common that it radiates, to a shoulder or an arm. It's also common to have some pain kind of up in the jaw and neck. And then where you get to those atypical presentations, so women, elderly, diabetics, you can have like a stabbing chest pain. They may not have any chest pain and just have really significant shortness of breath or fatigue. You can get dizziness, you can get nausea. So all of those are kind of additional things that can clue you in that they may be having an atypical presentation. You really want to be, what's going on with this patient and how are they presenting and looking to me? And if your senses are telling you that something's off, you want to be thinking about the chance that they could be having an atypical chest pain presentation. For most of these patients, position of comfort is going to be sitting upright. Most of them are not going to like very much laying down flat. And so there's two kind of medications that OEC6 talks about. And so this is going to be very dependent on what your Hill policies are. If you have, certain medical protocols, if your local EMS, has some integration with you. But the two kind of medicines that are, very common in the pre-hospital environment is one is aspirin. And aspirin is indicated in any patient that's having chest pain. So most of the heart attacks are going to be caused by a blood clot that's in one of the coronary arteries. And so that blood clot is going to have platelets in it. And that's what's making the blood kind of stick together and clot. So aspirin is going to help those platelets be less sticky so they won't stick together. And then if you suspect that a patient's having a heart attack, they may have already been seen by a cardiologist. They might be given instructions to take aspirin. OEC6 says that you can assist if your kind of local area protocols allow for that. The ideal thing for aspirin is that it's chewed. You don't want to take, the coated tablets and then them swallow it because those take a while to get into the system. So even if they have non-chewable aspirin, you can still chew it. It just doesn't taste very good. But chewing is preferred. And then the dose is 325 milligrams. So if it's baby aspirin, it's 4 of them. And then the other is nitroglycerin. So nitroglycerin is going to be a prescription medicine. It's not over the counter like aspirin. It's sublingual, so it goes underneath the tongue, and they have it dissolved completely there. You want to tell the patient not to chew it or swallow it. It's meant to dissolve sublingually. You need to check their blood pressure. If their blood pressure is over 100, then you're good to go. If it's less than 100, it would be contraindicated. Nitroglycerin is a really potent vasodilator. So it is going to open up their blood vessels, hopefully getting more blood flow to that heart tissue that's having that infarction. But if their blood pressure is already low and they take nitroglycerin, it's going to make their blood pressure even lower. They can do up to 3 doses. Those are at 5-minute intervals. And that includes any doses that they may have taken before you got there. Very common to get a headache with nitroglycerin. So a little tangent there, migraine medications. So all those kind of new migraine medications that we have actually cause blood vessels around the brain to constrict. So when you have your blood vessels dilate, it can give you a very similar presentation to a migraine-like headache. So the other piece of this, because one of the tools that we have in our arsenal is oxygen. And there's been a lot of literature that's come out recently with regards to supplemental oxygen in someone that's having a heart attack. And so OEC6 kind of takes a very like pure stance on this, which is if they're hypoxic, then treat them. If they're not hypoxic, then don't just give them oxygen to give them oxygen. And the reason for that is really coming out of a lot of the research that's been done by the American Heart Association as well as other entities. And so there was a study done called the AVOID study, and they kind of separated patients into two groups, and regardless of oxygen level, they gave one group high flow oxygen. And what they actually found is that it may actually be harmful because you are reducing some of that coronary blood flow, you get more resistance, and it can affect the microcirculation. So, they've done a lot of randomized trials now at this point, and basically it's not shown to have any clinical benefit to just supplementally give someone with a heart attack oxygen. And so it's appropriate to not give them oxygen if their blood saturation is totally normal. If they're satting 95% on room air, you don't need to give that patient oxygen just because you think that they're having a heart attack. And really what these patients need is they need to get to the cath lab. So the ideal kind of timeframes for this is that it's within 12 hours of symptom onset. And then once they get to that emergency room, the goal is to, from the door, when they enter the door of the emergency room to when they're actually on the table having the procedure in the cath lab and they're opening up that artery, is 90 minutes. And so one of the things that is, going to be common in our situations is that because we activate EMS and it's a patient that's having chest pain, they're really going to get routed to a cath lab facility. If for whatever reason they end up at a hospital that doesn't have it, their goal is to kind of rapidly transport that patient to another facility that has a cath lab to be able to do that definitive treatment. The other thing that can happen that you'll see as a presentation of chest pain is if someone is having an aortic dissection. So coming out of the top of the heart is the aorta. It has a couple branches that go off, and this is important for one of the symptoms that can give you a clinical clue that a patient might be having this. And so you can have dissection. You can have a dissection at multiple points along that aorta. And the classic presentation for this is that this is going to be a patient that is describing a tearing chest pain. So if you have a patient that has a tearing chest pain, it's radiating to their back, you need to have a very high index of suspicion that this could be a patient that's having an aortic dissection. They will also have hypotension, nausea, shortness of breath. And so one of the things that you may discover on physical exam is that they will actually have a difference in the blood pressure between their left arm and their right arm. And that's because the blood going to the right arm and the left arm are at two different points on the aorta. And so if you have a dissection that's affecting one of those points, you'll actually get that, difference. The other thing that you can sometimes find in patients when you're listening to their lung sounds, you may actually hear a really strong like swishing sound. And so patients that are having aortic dissection can actually have new onset heart murmurs. You can see neuro deficits because some of those, two of those branches are also going up to the brain. So they might have neuro deficits. And then anytime that you have a patient that is having pain above the diaphragm and below the diaphragm, that's another very unique kind of clinical picture of someone that's having an aortic dissection. These are very serious. 40% of patients that have an aortic dissection have immediate death. And then it increases about 1 to 2% for every hour that it's unrecognized. So these are very emergent conditions. It's also a pretty rare complication, but ski areas are getting wild. This can be a complication of cocaine-induced hypertension. So if you have someone that was doing cocaine on your hill, cocaine may actually be one of the contributing causes of an aortic dissection. So I want to talk about some of the American Heart Association CPR guidelines, and I'll kind of give you a little sneak peek of what they changed in 2025. Not as significant as what we saw with the changes of the Heimlich maneuver, but really a spotlight on one issue that certainly is becoming very prominent and something that we need to think about at our ski resorts. And we'll talk about the OEC indications for that. So the chance of someone having survival from cardiac arrest out of the hospital decreases by 10% every minute without CPR. And of the people that have cardiac arrest who get a shock from an AED in the first minute, 9 out of 10 of those patients live. So the very, very, very critical thing for us as patrollers is to have someone immediately getting the AED and activating our EMS response so that we can get that person to higher level care. We're going to do our normal process of checking for breathing and pulse. And then depending on if we have, normal breathing, normal pulse, we're going to be monitoring them. If there's no breathing, but we feel a pulse, we're going to do those rescue breaths, 1 every 6 seconds. And we want to continue checking for that pulse in case we need to convert to CPR. And if they have no breathing or agonal breathing and no pulse, then we're going to go to the bottom part of this algorithm, which is going into our CPR. What the American Heart Association added in 2025 is that within that first part of starting CPR, they talk about seeing if this patient has signs of opioid overdose. So namely that they have pinpoint pupils and administering Narcan. So it's really part of a push as a lot of state laws have changed. Narcan's now over the counter. You can get it without a prescription. There's a lot of things that are kind of evolving in this space, as well as some of the opioid epidemic problems. But that's what's going to be coming when you renew your CPR at your next cycle, is that there's going to be this kind of new emphasis on Narcan and evaluating for opioid overdose as part of this CPR algorithm. We really want to, as soon as possible, get that patient onto an AED, follow the AED prompts, and then if we give a shock, we immediately resume another 2 minutes of CPR until we do another pulse check. So that heart is still in a vulnerable state after a shock. We want to go back to high quality CPR, get through that 2 minute cycle, and then check for a pulse then. With pediatric patients, the guidelines, very similar to the adult. Very little has changed. What they talk about here again is that if there are signs of an opioid overdose, we're going to administer that Narcan. Now, one of the things that is different with a pediatric patient is that if they're not breathing and we feel a pulse, we're going to do rescue breathing. However, if their skin signs are very poor, so they have ashen skin, they are, cyanotic, if they don't look like they are doing well, even though you have started doing the rescue breaths and you have optimized their airway, if their heart rate is less than 60 per minute, you will actually start CPR if they have poor perfusion, because their heart rate is just not sufficient to actually be adequately perfusing their body. And again, AHA is really putting an emphasis on looking at Narcan as being one of those other things that we want to be thinking about anytime that we find a patient that is in cardiac arrest. So with pediatric patients, again, if you are one person, you're going to be doing 30 compressions to 2 breaths. Once that second rescuer arrives, then you're going to be doing 15 compressions to 2 breaths. Kids just don't have the cardiac etiology that adults do. They haven't been eating steaks for 40 years. They don't have high cholesterol. They don't have all these medical conditions. Their heart is pretty healthy. Respiratory arrest is usually the cause of cardiac arrest in a pediatric patient. And then AEDs have pediatric modes, pediatric pads, or capabilities that you can use them on pediatric patients. So you want to really know the devices that you have on your hill and if they're compatible with pediatric patients and what you need to do to ensure that they're compatible. So I think this is a big, I think a lot of what we're seeing around us is a big wake-up call to us in ski resorts. We have seen a huge increase in fatal overdoses. This is primarily from non-medically indicated use or abuse of prescription pain medications. We are seeing overdoses in heroin and fentanyl, and it's largely preventable. And we do now have a very safe remedy and antidote to opioids, which is Narcan. So Narcan restores that respiratory drive, and it doesn't have any psychoactive properties. It's not a controlled drug. You can get it over the counter. There's no dependency on it. So it's very safe to administer Narcan to a patient that has an overdose. And that's part of the shift that we're seeing in the pre-hospital environment. Drug overdoses are now the largest cause of accidental death in the US. So they are rapidly increasing. And the problem is really fentanyl. So fentanyl is 100 times more potent than morphine and 50 times more potent than heroin. We don't have a way to tell by sight, taste, or smell when a drug has been laced with fentanyl. They do now sell fentanyl test kits for people if they need to, double check that their drugs aren't being laced. But this is becoming a really big problem. And fentanyl is incredibly strong when it is laced with different recreational drugs. So Narcan, I think the way to think of this, so it's an antidote. It reverses the effect of opioids. And it is kind of like the children's shake toys. So all of our cells have different receptors on them, and opioids will bind to some of those receptors. The way that Narcan works at the cellular level is that it goes in and plugs those holes. And so when the Narcan has plugged those holes, that opioid drug has nowhere to interact with the cell. And so that is how Narcan effectively reverses the opioid overdose. At least in California, I'm not sure about Arizona and Nevada. I know there's a few of you on this call as well. California law changed back in 2013 that it protects any person that administers Narcan to an individual that's suspected of having an overdose from any civil liability or any criminal prosecution. You have full immunity if you, in good faith, give Narcan to an individual that you believe is having an opioid overdose. So I know Hills are developing policies on this, and some Hills will allow it. The OEC text talks about it, and it really talks about it being a Hill level decision that you need to have policies and procedures in place. It's kind of an and a constantly evolving part of our laws and legal framework. So I'm sure we'll see some more about this in OEC 7, and it'll be interesting to see where NSP lands on this issue. But as a side note, if you are a parent, you can now get Narcan over the counter. It, I think, is very valuable to have, with your stroller, in your car, carry with you, because if one of your kids, picks up a candy at the playground and it's actually fentanyl, this could be something that could save their life. So, aside from our ski patrol work, just as a parent and a citizen, it might be valuable for you to have Narcan available. So we'll jump into some of the neurologic conditions now. So when we are assessing neurologic status, we're kind of looking at it from two different angles. So one is just their alertness and responsiveness. That's AVPU. So are they fully awake? Are they opening their eyes? Are they aware of their surroundings? Are they only responding to us when we talk to them or ask them a question? Are they only responding to us when we do some sort of painful stimuli? Or are they totally unresponsive? When we talk about alert and oriented, we're talking about person, place, time, event. So who are you? Where are you? What day and time is it? What just happened? There's also the Glasgow Coma Scale, which is looking at kind of head injury severity based on certain eye, verbal, and motor criteria. I think that's kind of hard to remember all of those categories. So really AVPU and ANO is really sufficient for what we need as ski patrollers. And then when we have altered mental status, there are a few things that we can address as ski patrollers that we want to keep on our mind as we are evaluating someone with altered mental status. So are they hypoxic? Are they hypotensive? Are they hypoglycemic? Is their blood sugar low? Or are they hypothermic? Because those four things we can address. We can give them oxygen, we can give them glucose, we can get them warm and in a warm environment out of the environment. The list of things that cause altered mental status. So that's the AEIOU-TIPS acronym. And it is just a whole host of things that we may run into that is causing someone to be altered. And so the point of this slide is really that there are a large amount of medical conditions that can cause someone to have altered mental status. And they are going to be largely things that we are not able to diagnose on the Hill. We're not going to know on the Hill if someone's in kidney failure. We're not going to be able to diagnose on the Hill that someone has an infection. That isn't our role to diagnose as OEC technicians. So really what we're looking at is what are the things that we can address and how can we recognize that this person has altered mental status that we need to prioritize our transport and load and go. So those rapidly reversible causes, again, hypoxia. So we can check their oxygen saturation with a pulse ox. If someone has a history of diabetes or takes insulin, that may be something that's making them hypoglycemic, especially if they're exercising more than what they usually do. Maybe they took some insulin, they forgot to eat a meal, they've been skiing. Especially if you see someone that has one of the insulin devices now that gives them the continuous glucose monitoring, that will give them little doses of insulin, throughout the day, rather than the kind of bolus insulin that they take with a meal. And then we do have to be thinking about opioids. There's a lot of recreational drug use at ski areas, and unfortunately, a lot of those drugs are laced with fentanyl and other opioids. So when we talk about acute mountain sickness, so switching to things that are going to be related to altitude, acute mountain sickness is usually going to occur within several hours to a day after their ascent. So high altitude, when we talk about altitude-related illness, is really above 8,000 feet. You can see it at 6,500 feet. If that person rapidly gets to elevation, that's more likely to cause problems. And a large part of this is that oxygen changes as we get to higher altitudes. So at 10,000 feet, the amount of oxygen that you take in with each breath is about 70% of the oxygen that you would take in at sea level. And so people with acute mountain sickness will kind of describe this as a classic like hangover symptoms. They'll have a headache, nausea, vomiting, loss of appetite. They'll get sleep disturbance, dizziness, lightheadedness. And then in about 3% of patients that have acute mountain sickness, they will go on to develop high altitude cerebral edema. And this is a life-threatening emergency. This is most common over like 9,600 feet. And you are going to start to see neurologic changes. So they may lose coordination and balance. They might have altered mental status. They can get fatigue, drowsiness, difficulty speaking, coma. You can even get hallucinations and some psychotic behavior, which are occasionally observed in patients with HACE. And so that transition, that progression from having acute mountain sickness to HACE can be as fast as 12 hours, but usually it's over 1 to 3 days. And the treatment for this is going to be oxygen and getting them down the hill, getting them back to sea level. Another thing that we will see on the hill is syncope. So this is someone that faints. And there are lots of different things that can cause syncope. And some of those causes are big red flags that we need to be aware of. Because if you see one of those red flags, that is someone that you really want to load and go. There may be something much more serious that's the cause of their syncope. So one of the most common that we're all kind of familiar with is vasovagal sympathy. And so this is going to be, you can see this prolonged standing in a warm room. So you might see it in your lodge. They have all their ski gear on. They've been skiing. They're a little bit dehydrated. They're standing for a long period of time. That can cause them to have a syncopal episode where they faint. Pain is another common cause of vasovagal syncopal episodes. You can have orthostatic hypotension. So this is going to be primarily in like elderly patients. They may have a syncopal episode while they are on the toilet and they are bearing down to have a bowel movement and they faint. If they're on certain prescription drugs that lower their blood pressure or lower their heart rate, if they stand too quickly, if they have something where they had a kind of change in posture, that can cause them for their blood pressure to go down. They'll get a syncopal episode, they'll faint. But then you can also have cardiac causes, you can have neurologic causes, and then even hypoglycemia can cause you to have syncope as well. So there are a couple red flags of things that people will describe, and this is before they have the syncopal episode. So if you respond to someone that fainted, and when you start getting your history on this patient, certain things are going to be red flags to where you really need to now expedite transport and higher level care for this patient. So if they are laying flat or they were laying down when they had their syncopal episode, that's very concerning. If they were having chest pain or palpitations or shortness of breath before their syncopal episode, that's also very concerning. Elderly patients, it's concerning because there are so many things that can be contributing that they really need to get evaluated for things like infection and all these other medical causes that might be related. If they had no warning whatsoever, most people, when they have vasovagal syncope will have some sort of sense that they're starting to get lightheaded, they're starting to feel like they're going to faint. Same thing with orthostatic hypotension related syncope. They're going to feel lightheaded and that they're going to faint. If it is someone that just fainted with no warning, nothing, that's a concerning red flag for us. And then anytime that someone has trauma plus syncope is a big red flag. During the actual syncopal episode itself, if there's any type of oral trauma, they bit their tongue, if they had any type of incontinence where they either soiled themselves or they had urine, those would be red flags, because with a typical syncopal episode, you're not going to have a loss of continence. And then if they fainted and were unconscious for a prolonged duration, that's also very unusual. Seizure activity, so if they actually had, tonic-clonic seizure activity, that again is more likely making you think that they had a seizure and not that they just had a fainting spell. And then after they faint, when you have vasovagal or when you have orthostatic syncopal episodes, you're not altered after you come back. So you will faint and then you will have a return of neurologic function. So if you have someone that's confused after they fainted, that's abnormal. If they have a bad headache, that's abnormal. If their vital signs are weird, they're still hypotensive, they're really tachycardic, those are also odd. You shouldn't be having that in that kind of post-syncopal phase. And any type of neurologic deficit is going to really raise alarms for you that you need to be expediting the care on this patient. Seizures can result from a lot of different things. There's a lot of things that trigger seizures. More concerning to us as ski patrollers would be head injuries. So if you have someone that falls, has a head injury and now a seizure, that's very concerning. Heat illness can trigger it. Infection, hypoglycemia, stroke, drugs is another one that you may have a drug-induced seizure. And so the common type of seizure that we are most familiar with is where they have what we call a tonic-clonic seizure. So the tonic phase is where their body is very rigid and stiff, and then they have that rhythmic jerking, and that's the clonic phase. Most seizures last 1 to 2 minutes. It is very common for someone that had a seizure to be very confused or combative. It's called the postictal time, and that can be anywhere from 10 to 30 minutes. I've had patients that have had seizures that were really aggressive and combative. So you do want to be aware of that. They are not going to like it if you put an oxygen mask on their face. They are feeling claustrophobic. They will not want to have people hovering over them. So you really want to be mindful, because you do have to be aware that this patient is quite altered and very common that they're combative. Kids may get absent seizures where they just have a kind of blank stare and they have a total loss of awareness. And then the other thing in younger children is that you can have febrile seizures. So one of our kids had a febrile seizure, very scary, related to the fact that they had a fever And so that is one of the triggers in kids. So if you're at the hill, I've certainly had this at the hill where, families come in for a ski trip, they pack up, they load in the car, they get to the top of the hill, they're a couple runs in, one of their kids isn't feeling so great, they stop by, we take a temperature, and they have a fever. So you may have, kids that weren't presenting sick when they got there, develop a fever, and that could be one of the things that might contribute to a seizure, especially in a young child. And so if we are seeing a patient seizing, or we're there and they are still seizing, the big things that we want to do, we want to protect them from any injury from their surroundings. It is ideal to turn them onto one side so that if they throw up, they don't aspirate. We do not put in bite blocks or any type of thing into their mouth. And then you burn a lot of sugar and energy when you have a seizure. So it is common that people after a seizure may be hypoglycemic. So you might want to be thinking about that once they regain their normal facilities and are a little bit more alert and oriented. You're not going to give it to them while they're unconscious, but that might be a patient that you give some type of sugar to help reverse any hypoglycemia that might be going on. Stroke is another thing that we may see on the hill. For strokes, this is one of the big distinctions from heart attacks. There are two different types of strokes, and their treatments are completely different. So you can have ischemic strokes where you actually have a blood clot or something that's occluding blood flow to the brain. And you can have hemorrhagic strokes where an artery in the brain ruptures and there is bleeding around the brain. Why this is significant to us is that in stroke patients, we never give aspirin. It is never part of the pre-hospital treatment. So aspirin is indicated for heart attacks in patients that have been advised by a cardiologist or have aspirin that they're carrying with them to take. That is appropriate in a heart attack. If you have a patient that is having a stroke and they have aspirin and they want to take it, you want to stop them from doing so, because if they are having a brain bleed related stroke, the aspirin is going to make it worse. Patients that are having strokes may have sudden onset headaches. We talked about earlier, high blood pressure is one of the big contributing medical conditions of stroke. So you may take their blood pressure and it's very high. You're going to potentially see some altered mental status and some focal neurodeficits. If it's really significant stroke, you may see like a blown pupil. So you definitely want to be looking in their eyes. That is the window into the brain. And then we also need to think about airway management for these patients. When we have strokes, you will see a lot of like left versus right, face versus tongue, speech, vision, hearing, anything that's related to their brain and their kind of neurological condition. You can have a stroke that impacts a different part of the brain that may be affecting one of those specific things. Subarachnoid hemorrhage is another type of really serious brain bleed that we can see. And so the classic presentation for this is what is called the thunderclap headache. So if someone is telling you that they have the worst headache of their life, that is a patient that you really need to have a high level of suspicion that they could be having intracranial hemorrhage. For 50% of patients, the maximum severity, so that worst headache of their life, is instantaneous. So they go from 0 to 6,000 instantaneously. And then 20% of patients will have it in 1 to 5 minutes, where they develop that worst headache of their life. This is caused by bleeding between the brain and its membrane. You can also see things like neck pain, nausea, vomiting, and you may get some neurodeficits and altered mental status. But these are all of these stroke-related things that we may see on the Hill is a patient that we need to load and go and get them to higher level of care. So the OEC 6 text talks about the fast ED mnemonic to remember this. So you can get facial drooping, mouth drooping. You might have eyelid drooping on one side of the face. You can get arm weakness, one of the tests that you can do. And if you look at OEC 6 figure 11-12, if you have a patient hold out their arms and close their eyes, you will get a drift in one arm in patients that are having a certain type of stroke. Common that they will have difficulty speaking or slurred speech. You may get kind of garbled words. And then the other thing that can happen in stroke patients is that they have expressive aphasia. So they can't find the right word. They can't get the right word out. So they can't say like, I'm thirsty, I need a sip of water. They'll kind of have this like, want water. They can't quite get a sentence together properly because of that neurological deficit. These are, again, any patient with stroke symptoms. We're going to be doing rapid transport off the Hill. You do want to check extraocular motion. There are a lot of cranial nerves that are involved in vision. And so that may give you some indications that that patient is having a stroke. They may have loss of vision in one eye. They may have double vision. Those are also common in certain types of strokes. And then a lot of times you can find that they have a denial of their deficit. So you're having them squeeze your hands, and one side is very weak. And then you ask them, do you feel weak on one side? And they can't identify it. So that denial can actually be one of the signs of a stroke. This is another very common mnemonic, be fast, but they're really all saying the same things. What I like about this one is that it also highlights that you may have loss of balance or kind of gait. Their gait is off. And then obviously, we're very familiar all with if they have one side face droop or unilateral arm or leg weakness. Those are certainly very concerning signs for us to see as patrollers. Airway management is really critical in these patients. And then it's really helpful for the hospital if you note when their last time normal was. And so, you want to, when you're getting that history of when they started having symptoms, you want to note what that time was, maybe write it on a piece of duct tape, last known normal and the time, and stick it on their jacket or something, because that is very valuable to the hospital. The American Heart Association, as part of their guidelines refresh, just kind of updated some of their guidelines with the treatment of stroke in hospitals. And so very similar to like what we have done with treating heart attacks, there are now labs that specialize in treating strokes. So if the patient gets to the hospital within 4.5 hours of their symptom onset, they're eligible for IV clot busting drugs that will break up the clot and reverse their stroke. And there are also very similar to a cath lab where they go in through a vessel. They will get up into the brain through the blood vessels and actually suck the clot out. And they can do that up to 24 hours after symptoms. If the patient is hypoxic, we want to give them oxygen. And one of the things that was interesting in this American Heart Association guidelines that just came out, there were a couple of clinical studies that have been done looking at if the patient is at a 0-degree head position in a bed versus being at 30 degrees. So, elevated their head of bed. And there was no clinical benefit, no difference between those two groups. So there is not a strong consensus that you need to transport a stroke patient either flat or sitting up. Do it in position of comfort. OEC6, I tried to look through quite a bit. I didn't see any recommendations specifically in OEC6 about how it recommends transporting these patients, but there aren't any really strong clinical guidelines that point one way or the other. So a little mini neuro exam. So this is something that that I like to do. We talked about that pronator drift. That's a great clinical tool where you have them hold their arms out, close their eyes. There's 12 cranial nerves, and I have a pretty quick little thing that I will run patients through where I address about 7 of them. So I will ask them to smile. I'll ask them to puff out their cheeks, stick out their tongue, raise their eyebrows, shrug their shoulders, and then I'll check their extraocular movements and their pupils. And you've tested 7 of the 12 cranial nerves right there. What was really interesting, I had to get a root canal done, and so the dentist numbed me up, and I kind of looked like I had had a stroke. You know, half my face was numb. So when I would smile, I couldn't get movement there. What was really interesting to me was that I tried to puff out my cheeks, and I couldn't because I didn't have enough muscle strength to keep my lips closed to actually puff in with air. And so part of why we have patients puff out their cheeks is that if they have a muscle weakness on one side of their face, they're not going to be able to puff out their cheeks because their lips won't stay sealed together. So I thought that was interesting, wanted to share it with you all. But really, this is so that we have we want to use this as a tool to figure out that they have something neurologic going on and that we need to get them to that higher level of care. That's really the only thing that we can do for them on the hill is get them off the hill to that higher level of care as soon as possible. So the takeaways for tonight, many of us will probably have heard this before, but time is tissue. So important with cardiac and neurologic emergencies that we really are mindful of how long are we on scene for, how quickly are we activating our resources, how fast are we getting that patient to the hospital for that definitive care. The other big takeaway, and OEC 6 talks about this quite a bit. I think it's one of the shifts that we've had over time in the pre-hospital environment is use oxygen appropriately. So if the patient is hypoxic and they have one of these conditions, then yes, absolutely, administer oxygen. But if that patient has a normal oxygen saturation, we don't want to just be giving them oxygen to give them oxygen. And then we really need to remember that women can present with atypical chest pain. They have been out skiing, they are, exerting themselves. If they have a heart attack, they may not come to you with chest pain. They may be coming to you with shortness of breath and fatigue. And so we also really want to be thinking about that as we are seeing patients that are giving us those kind of indications that they might be big sick. You don't want to forget about that you might have a patient that has a cardiac origin to their kind of vague symptoms, especially in women. So let me stop presenting and we will happy to do some Q&A with you all.